Welcome back. In this podcast, we'll be discussing about the management of the trauma patient according to the Advanced Trauma Life Support Principle. We begin by performing a primary survey, which comprises of 5 steps. Firstly, is the airway and cervical spine protection, followed by breathing and ventilation, then circulation and hemorrhagic control, followed by disability and neurological status, and finishing off with exposure and temperature control. The principle of airway management is to establish an airway with limited mobility of the cervical spine. The airway management uses a stepwise manner approach. Firstly, look for any evidence of airway obstruction such as stridor, gurgling, noisy breathing, or silent patient. Suction any blood, clots, and secretion from the oropharynx and remove any visible foreign bodies from the oral cavity. Be wary of the patient with major facial or neck injuries, as it can potentially make airway management a difficult task. Inhalation injury can cause delay in airway obstruction, hence early intervention is warranted during such situation. If the patient maintains his or her airway, a mask ventilation may be sufficient. However, if there is any clinical signs of obstruction, begin by simple airway maneuvers such as a jaw thrust, followed by simple airway adjuncts such as a nasopharyngeal airway or oropharyngeal airway that can provide a temporary airway for an obstruction at the level of the tongue base or nasopharynx. Bear in mind, oropharyngeal airways may not be tolerated in conscious patients, whilst nasopharyngeal airway usually are better tolerated in such situation. Supraglottic airway device such as a laryngeal mask airway allow ventilation without visualizing the airway and does not require the patient to be paralyzed during insertion. However, the disadvantage is it's a less stable airway and does not protect the airway. Any patient with a GCS less or equal to 8 would need intubation, and any attempt of intubation should always have a backup plan of an emergent surgical airway. Intubation can be performed either through the nose or mouth. Nasotracheal intubation generally are better tolerated in awake patient and can be accomplished without neck extension, which is a appropriate choice for patient with severe mandibular fracture or cervical spine fracture. We can also utilize video laryngoscope or flexible bronchoscopy to help in difficult airway cases. If intubation fails, we are in the realms of surgical airway techniques such as needle, open cricothyroidectomy, or tracheostomy. Surgical cricothyroidectomy would need to be converted to a formal tracheostomy within 24 hours, as the small tube can be difficult to clean, as well as prevention of subglottic stenosis. The patient's cervical spine movement should be restricted or minimized until any cervical spine injury have been excluded. This can be achieved by using the cervical collar, sandbags, and straps. After establishing a secure airway, we must evaluate the patient's ventilation and oxygenation. This can be done by looking at the chest wall movement as well as listening to the lungs for air entry. It is important to calculate the respiratory rate, have a feel for any tracheal deviation, and obtaining the patient's oxygen saturation. We must exclude life-threatening conditions such as tension pneumothorax, open pneumothorax and massive hemothorax. Patient with a tension pneumothorax presents with hypoxia, restlessness, hyperresonance on percussion, decreased air entry, contralateral tracheal shift, and elevated jugular venous pressure. This can be treated with a needle decompression, where a large bore cannula is inserted through the second intercostal space at mid-clavicular line for children and fifth intercostal space mid-axillary line for an adult. After decompressing the tension, a chest drain should be inserted as a definite treatment. As for patient with a open or sucking pneumothorax, a three-way dressing should be placed around the wound, which work as a valve to prevent airflow into the chest cavity during inspiration and allow pneumothorax to drain through the open wound during exhale. There are conditions such as intracranial injury, opiates, and alcohol which can reduce patient respiratory drive. To complete the breathing evaluation, one should request for an arterial blood gas as well as a chest x-ray. In the assessment of circulation, we are looking for any evidence of shock. Shock is defined as inadequate end organ perfusion, where patient may present with tachycardia, hypotension, pallor, reduced urine output, or lethargy. Patient with any evidence of shock should have at least 2 large bore cannula inserted intravenously. Consider intraosseous access when intravenous insertion has failed on multiple attempts. The line should not be inserted on the same side as a vascular injury. Fluid bolus should be given to a patient to improve their blood pressure and maintain organ perfusion. However, in patients with evidence of hemorrhagic shock, early blood transfusion should be considered. Patients with neurogenic shock may present with hypotension, bradycardia, and warm periphery, which can mask a hemorrhagic shock. To assess circulation, we think about doing central and peripheral pulses, capillary refill time, and blood pressure. We should also request for cardiac monitoring, blood tests such as full blood count, cross-match for blood transfusion, and a urinary catheter for monitoring of urine output. The principle of hemorrhagic control is to stop the bleeding. Think about 5 compartments in the body. First is the chest. Second is the abdomen. Third, long bones. Fourth, pelvis. And last but not least, on the floor. The degree of hemorrhagic shock can be divided into 4 classes depending on the amount of total blood volume loss. Class 1 is 15%, Class 2 is between 15 to 30, Class 3 is 30 to 40, and Class 4 is more than 40%. To assess the patient's disability and neurological status, we firstly look at the patient's pupils to check for reactivity. We divide the patient's head injury classification according to the Glasgow Coma Scale, which is a scale based on the motor, verbal, and eye response of a patient in a scale of 15. Patient with a score of less than 8 has a severe head injury, 9 to 12 moderate head injury, and more than 13 as mild head injury. If there is a clinical suspicion of a spinal injury, we can further identify the level of the injury by performing power and sensation in the patient's periphery to identify the level of injury. The final part of the primary survey is exposure and temperature control. This is to avoid missing any associated injury that has not been covered in the previous assessments. It is important to keep the patient warm and prevent hypothermia, and this can be done by warming fluids, putting blanket on the patient, using a bear hugger, and performing peritoneal or bladder lavage. Once a trauma patient has been appropriately stabilized and all life-threatening conditions have been treated in the primary survey, we can proceed to performing a head-to-toe examination in the secondary survey. This is to look for any non-life-threatening condition that need to be treated in a trauma patient. A brief history can be obtained from the patient using a mnemonic ample, which is allergy, medication, past medical history, last meal, and the events preceding the injury. I hope you have enjoyed the revision for the management of a trauma patient. Hope to see you all soon.